Inflammation of cornea is called keratitis, and keratitis is part of the red eye diseases. How can we differentiate between red eye in conjunctivitis and red eye in keratitis? It is the type of injection. While in conjunctivitis we have conjunctival, most prominent in the fornices, and little by little becomes bed around the limbus, and it is these are the superficial vessels that are inflamed, and if you instill one droplet of adrenaline, the eye will become white. In keratitis, the type of injection is ciliary. So the periphery, the fornix of the conjunctiva is nearly fine, but around the limbus, there is the greatest redness, and it is red bluish in color. And if you put adrenaline, it will stay there because deeper perilimbal vessels are engaged. So pain, as we mentioned, first branch of trigeminus innervates the cornea, and even a small fly, if enters the eye, it's pain, blinking, tearing. You can't tolerate it because of the rich innervation. Unlike conjunctivitis, which has pathological discharge, but visual functions are usually not impaired, although we mentioned of some more severe entities like epidemic keratoconjunctivitis or spring catarrh that might affect vision, but as a rule, in conjunctivitis we have normal visual acuity. Keratitis usually is present with different degree of impairment vision. So when you have epithelial edema, there is diffraction of the light, and people see this halo around light, a lamp, that is really dissociated, not white, but colored, dissociated white light into colors. This halo, colored halo, usually is a result of epithelial edema. It is also characterized in whenever we have epithelial edema, not only in inflammation, but for example in raised intraocular pressure, which gives this epithelial edema. So photophobia is great. So photophobia usually is due to slight iritis, also keratoiritis, and this hypermeiosis in inflammation. Blepharospasmus, okay, you can't, because of photophobia, you keep the eyelids tight, like in spasmus, and reflex stimulation of the nerve endings lead to tearing epiphora. As I mentioned, in ophthalmology we have different terms. Photophobia for light sensitivity, tearing for epiphora. So you remember chemosis for the edema of conjunctiva, injection instead of hyperemia. So, and we can see some clouding on the cornea, clouding. So these are the symptoms of corneal disease. How can we mostly prove what diagnostic methods we use in corneal disease? First of all, observation. as we mentioned, typical phase of tearing, photophobia, blepharospasmus gives the idea of a corneal disease. Then we can't examine such a patient. He normally can't open the eye. What to say to bring light through biomicroscopy? Okay, then we instill topical anesthesia, and next thing we do, we dye with fluorescein dye. We put this dye into the eye, and if there is some epithelial defect, it will stain in green while we observe it with blue light of the biomicroscopy. So this staining of the epithelial defect will actually give the marks, the boundaries of the defect of the epithelial. In cases of herpes, you'll see this defect like branching of a tree because of these nerves that branch from the anterior stroma in between the epithelial cells. So the branching is like a tree. So it's herpes dendritica. You can see how typical it is in a moment. Another method, especially when we herpes, we have pain but decreased sensitivity, and you can place the cotton and no reaction, like reflex of blinking or reacting will take place. So another method, keratometry, is to measure two main meridians, but not by numbers. As we mentioned in a refraction lecture, we rarely use the numbers, how many diopters the whole eye has, the physical refraction so-called, but in some cases, as we have to measure the intraocular lens, and in the formulas there is the two meridians of cornea in diopters, we have devices to measure this keratometry, and in some autorefractometry, besides sphericylindrical axis, we have also measured the two main meridians in diopters. Pachymetry is a method to measure the thickness of the cornea. You can do it through ultrasound pachymetry usually, and you measure how much microns the cornea thickness is. It has the following clinical importance. If you have thicker than 500 micrometers, then that will give a thicker cornea, will give false higher intraocular pressure. And if you have a thinner than 500 micrometers, then you have false lower intraocular pressure than the actual one. So you need pachymetry to recalculate intraocular pressure according to the thickness of the cornea, and there are some tables how much you have to put on or take off numbers from the one measured according to the thickness of the cornea. We mentioned about corneal sensitivity and fluorescence staining. Specular microscopy counts the endothelial cells. Why? Because we know they don't regenerate, and through aging the number is decreased, and before undertaking surgery for cataract, you count them to see how risky this surgeries to impair cornea. And corneal topography is not only the central thickness of the cornea given by pachymetry, but the thickness of the whole cornea, giving like colored 3D image. And it has its diagnostic methods. For example, it's absolutely necessary diagnostic method for refractive surgery, as well as for diagnosis of keratoconus. So the corneal diseases also can be congenital. First, to pay attention on the congenital anomalies. So then we have inflammatory and degenerative diseases. Later on in the lecture, let's start with congenital. Classification of congenital anomalies. These are anomalies of the form of the cornea, anomalies in the structure of the cornea, infectious impairment of the cornea, and mechanical impairment during time of delivery. So we know congenital anomalies are those present at birth. So anomalies in the form, we can have bigger than normal cornea, megalocornea, smaller than normal cornea, microcornea, flatter cornea, planocornea, or we can have posterior keratoconus. So anomalies in the structure, you can have posterior embryotoxon, Axenfeld trigger syndrome, Peters anomaly, posterior keratoconus, sclerocornea. These anomalies are usually of the cornea and anterior chamber angle, so they are part of also as a result glaucoma, most of them. Some people, for example, babies are born with after intrauterine infection with some keratitis, like in rubella, or some trauma at the time of delivery. Let's have a look at those anomalies. So, microcornea is smaller than normal. We should know what the normal is in order to decide which of these two eyes is abnormal, the one that looks smaller or the one that is bigger. In adult, the normal diameter of cornea is 11.5 millimeters. That's the horizontal diameter is 11.5 millimeters. So microcornea is smaller than 10 millimeters. It is often accompanied by microphthalmos, smaller eyeball. Here we have to make differential diagnosis of microphthalmos and nanophthalmos. Nanophthalmos is also a smaller eyeball, but it is a healthy eye. No structural other anomalies are present. It is clinically expressed only by severe hyperopia, because small eye will have the focus much behind the retina, so it is with high hyperopia but healthy eye. While microphthalmos is a small eye but with some real other impairment like congenital cataract, persistent hyperplastic embryonic vitreous, coloboma of choroid, hypoplasia of the optic nerve, etc. So microcornea in microphthalmos is some impaired eye. Megalocornea is bigger than 13 millimeters. Sometimes it can reach 16, 18 millimeters. So it is sometimes familiar and it is bilateral. It's more often in males. But when we see a baby with big eyes, as pediatric ophthalmologists, we are always alert about congenital glaucoma, which starts with these big eyes. Unlike congenital glaucoma, megalocornea is isolated finding. You see, there aren't any clinical sign of a disease, just eyes are white, normal, not tearing. While in congenital glaucoma, there is light sensitivity, the symptom of mother's shoulder. Babies keep their eyes in the shoulder of the mother. They are hiding away from light, tearing, and this limbus becomes stretched here, bluish, and ophthalmos, the eye grows, and because tissues are not solid in babies, the raised intraocular pressure is expressed first in the anterior segment of the eye. The eye stretches, becomes bigger, ophthalmos, and later on the optic nerve gives atrophy. While in glaucoma in adults, the tissues are already, layers of the eye are already solid, so this increased intraocular pressure attacks the optic nerve first, the posterior segment, and don't have this picture of big eye and ophthalmos like in congenital glaucoma. So keratoconus is a progressive thinning of the cornea. It gives blurry vision, nearsightedness, astigmatism, irregular. Light sensitivity, it is bilateral usually. And keratoglobus, by its name, the cornea have the form of a globus because of diffuse protrusion and thinning of the peripheral cornea. Keratoconus is the central cornea, and in keratoglobus is the thinning of peripheral cornea, so that it gives the form of keratoglobus. Sclerocornea is rare anomaly, can be accompanied by glaucoma. Here is the normal profile of a cornea. Here is the central thinning giving this keratoconus form. This is peripheral thinning giving the form of keratoglobus with deep anterior chamber. This is sclerocornea, more milder case and severe case of sclerocornea when cornea is also white like the sclera. It has lost its main function as a refractive structure to be shiny, smooth, and transparent. So the next type of anomalies of the cornea is anomalies in the structure, and they are called Iridocorneal Dysgenesis because anterior chamber angle is also involved. These are posterior embryotoxon. This is thickened and centrally displaced anterior border ring of Schwalbe. Axenfeld anomaly, posterior embryotoxon and goniosynechi. These are synechiae towards anterior synechiae, towards not towards the lens, but towards the anterior chamber angle. When there is raised intraocular pressure, the anomaly is called syndrome, plus glaucoma actually. Rigor anomaly, we'll see picture in a moment. It's a microcornea, posterior embryotoxon, atrophy of the iris trauma with correctopia, pseudopolyporia. In 60% there is glaucoma and it becomes syndrome. Also it has typical dental abnormalities, fewer teeth, hypodontia, teeth that are smaller than normal, microdontia, cone-shaped teeth, cranial facial abnormalities. Flat nose, widely spaced eyes, underdeveloped bones of the upper jaw, hypoplasia of the upper jaw. This umbilical hernia is very typical. So you see it's overall syndrome, not just the glaucoma present. And Peters anomaly, we have central corneal opacity due to dysgenesis of anterior segment during development. Also 50% of this is glaucoma. This is posterior embryotoxon, this displacement of line of Schwalbe anteriorly. You see it like peripheral, such line, it's embryotoxon. When it has also synechiae, we have Axenfeld, embryotoxon plus synechiae makes Axenfeld anomaly, and when it has raised intraocular pressure, we have Axenfeld syndrome. Here is Rieger anomaly. You see the teeth, umbilical hernia, you see polyporia and hypoplasia, iris hypoplasia. Here are anterior synechiae. This is the structure of the anterior chamber angle, and you see synechiae towards the angle, which can give secondary glaucoma. And that's Peter anomaly, this central clouding with also problem in the anterior chamber giving raised intraocular pressure. So that's about congenital abnormalities of cornea. So what are inflammatory diseases of the cornea? These are keratitis. They can be bacterial, viral, fungal, single cell organisms, and acquirers should be very aware of. Interstitial keratitis and marginal, they all have different clinical picture. So bacterial keratitis can have dramatic picture, okay? In ours, the cornea might be melted and destroyed. Why it, thanks God, it doesn't happen very often, though we can have very often bacterial conjunctivitis. Why, thanks God, we don't have bacterial keratitis so in every bacterial conjunctivitis? Because of biological barriers of the eye. This is the composition of the tear film, you remember, with these lysozyme antibodies and so on. And because of epithelial and Bowman membrane. Remember, Bowman membrane is biological barrier, not the toxin of not every bacteria can really invade the cornea through the Bowman membrane. So, But there are some very virulent, very aggressive bacteria that can invade intact corneal epithelium. This is diphtheria, Pseudomonas, Neisseria, Haemophilus influenzae, Listeria species. But for most of other bacteria, in order for the infection to take place, there should be some erosion. The corneal epithelium should be not intact, like small trauma, like in manipulating with contact lens not properly, like dry eye, like diabetes, poor local immunity, like in AIDS or whatever. Some alteration in the normal cornea defense mechanism. Serial ocular problem, rapid progression, ulceration, abscess formation, surrounding cornea edema, anterior segment inflammation, usually keratouveitis, can invade through 4 stages: progressive infiltration, active ulceration, regression, and healing. Healing spontaneous if cornea is ruptured, and then the healing might take place spontaneously. So symptoms: pain, of course, red eye, ciliary injection. You see ciliary injection, but it's mixed. The whole eye is red. Okay. Photophobia, blurred vision, mucopurulent or purulent discharge, but not in the conjunctival fornix, but inside the anterior chamber. You see this white accumulation in the anterior chamber. It is pus inside the eye, and it is called hypopyon, pus in the anterior chamber. Here it is the infiltration of the cornea with such epithelial defect, because it is stained with fluorescein. You see green when you look with blue filter. That's the epithelial also involved. We can have hemosis of conjunctiva, swelling of the eyelids, significant injection, epithelial defect with infiltrate involving large corneal infiltration, stromal edema, faults in decimate membrane, also anterior uveitis with hypopyon. Actually, hypopyon is a sign of uveitis, of anterior iridocyclitis, but very often we have here keratouveitis. That's why we have this hypopyon. Besides this infiltration of the stroma, the infection is deeper to involve uvea as well. Also, you have these precipitates on the endothelial, posterior synegia. These are synegia towards the anterior lens capsule. Severe ulceration, perforation may be a result, you see here. Scleritis, keratoscleritis, keratouveitis, even endophthalmitis. You see, this is the whole eye is with bacterial infection. Treatment is antibiotics. In case of perforation, you put a bandage contact lens for small perforation, but you should control the infection very well. Use a tissue glue. Or later on, when the inflammation is subsides, fortunately, and has not this bad ending as we spoke about, you can perform keratoplasty. And if cataract is a result from the inflammation, you can also remove the lens. But the survival of this graft after severe inflammation is not so favorable like in the keratoconus. The graft corneal patch cornea transplantation is with best result when there aren't signs of inflammation like in keratoconus. But after chemical burn, after severe keratitis, the risks for rejecting the transplant is big. So, viral keratitis are more often seen in the clinic. We have two, most often we have herpes keratitis, type 1 and type 2. We spoke about it in eyelid diseases, and herpes zoster. That's the typical dendritis keratitis. So, like branching like a tree, and you stain it with fluorescein. It's very typical for herpes. You do this sensitivity testing to prove it, and we have treatment, Zovirax, acyclovir, like tablets or Unventum. And the first attack of keratitis by herpes simplex can subside by itself if you don't hinder. Sometimes, if you start treatment with antibiotic, corticosteroid, you can make it worse. So first attack is fine. The problem is the recurrences. So you have to treat it very careful not to have as a result some scars on the cornea like numbecula macula. Okay? What else important here? When you have corneal defect, something that stains with fluorescein, corticosteroids are contraindicated. Local corticosteroids like droplets will worsen the situation of the epithelial. So when the cornea is staining, no corticosteroid. So when we have very aggressive herpes, you can have this geographical keratitis, more spread impairment of the epithelial. And when you have very bad local and general immunity, you can even have necrotizing keratitis, very severe picture. Invasion of the herpes into the keratocyte and just melt the cornea. So different clinical pictures, and one very specific is disc-deforming keratitis disciformis. It's like a disc, this small opacification central, like a disc, into the stroma. So it doesn't stain with fluorescein because it's deeper into the stroma. Sometimes you can see some precipitate. It's not the active virus, it's toxo-allergic reaction towards the virus, so it is treated with corticosteroids. Very good response to corticosteroids. Herpes zoster keratitis, we spoke about herpes zoster in eyelid diseases, and so you have this rash, papula, pustula, crust, and scar. And cornea involvement can take place as well. We can suggest it when we have Hutchinson sign. Here, eruption on the peak of the nose. That means nervus nasociliaris is involved. Then we can have different form of corneal involvement, punctiform epithelial keratitis, microdendritic ulcers, Keratitis numularis, Keratitis disciformis. Sometimes it resembles very much herpes simplex keratitis. Unlike herpes simplex, herpes zoster does not give recurrences, but it gives some neurotrophic impairment. So long after this infection is gone, people might feel this paresthesia, some discomfort, dry eye, like symptoms of infection while there is not real infection. It's the impairment of the trophic function of the nerves of the cornea. We can have, of course, other viral keratitis, Epstein-Barr, parotitis morbili. So recently we had one viral keratitis by morbili, a child that was just discharged from infectious Institute for Infectious Diseases with diagnosis of morbili, and he shows up with bilateral keratitis like numularis, like in epidemic keratoconjunctivitis, if you remember from our previous lecture. This is a picture to be taken very seriously by contact wearers. If there are some contact wearers among you, you should really increase your hygiene and the important responsibility to really manipulate carefully with contact lens. It's usually either result from trauma or decreased immunity. The causative, usually it's bad hygiene of the lens, and there are some candida on it, or even these unicellular organisms like Acanthamoeba. So this is this infiltration with hypopyon. But the difference from bacteria is it's a little bit dry infiltration and hypopyon. You see the difference? And it can be very bad result, okay? You treat with antifungal. You have like infusion or like local treatment. So interstitial keratitis are those that don't infect the endothelial but the stroma of the cornea. These are interstromal inflammation as a result usually of immunocompetent cells. Слушам. Не имам лекция в момента, съжалявам. Sorry, I had to answer because I'm expecting some couriers. So sorry for interruption. So this interstromal inflammation is a result of invasion of immunocompetent cell releasing cytokines in general infectious disease. Usually interstitial keratitis we have in some systemic diseases like congenital wounds, like sarcoidosis, tuberculosis, varicella, rosacea, and so on. We have to define the main diagnosis and treat it generally. So we have this Cogan syndrome with bilateral stromal keratitis, hearing loss, and arthritis. That's why it's syndrome. One very typical is marginal keratitis. You see injection of the conjunctiva, And here, staining, peripheral infiltrates, peripheral staining. It is one exception that when we have staining, we put corticosteroids, only in marginal keratitis, because it is supposed to be hypersensitivity towards exogenic allergen. Hypersensitivity towards exogenic. And like Streptococcus and Flic-10, you remember what Flic-10 of the conjunctiva is? It's hypersensitivity towards endogenic allergen. So it needs treatment with corticosteroids. Corneal dystrophies are another big entity of corneal diseases. They are not very often found in the everyday clinics, thanks God. They can be affecting the epithelial, the stroma, and endothelial. Here, epithelial dystrophies, actually these are dystrophy that affect the anterior segment of the cornea, epithelial and anterior stroma. It gives thickening of the Bowman membrane and recurrent erosion, like 3-4 MEP fingerprint dystrophy, Misman corneal dystrophy, like vesicles intraepithelial, Rice-Buchler dystrophy is fibrovascular tissue which substitutes the Bowman membrane. Also, all these epithelial dystrophies give us clinic recurrent erosions and decrease little by little decrease vision. Treatment of these recurrent erosions is our soft contact lenses or sometimes laser keratectomy, excimer laser. The dystrophies that affect the stroma, deeper layers, the stroma can be with accumulation of different non-degraded substances like highly in the anterior stroma in granular dystrophy. It can, you see, progress dramatically. It can progress. Like lattice dystrophy, accumulation of amyloid in anterior stroma, and because it's more in the anterior, also can give those that are in the anterior stroma can also give recurrent erosions. And macular dystrophy is glucosamine glycan in the stroma, and it gives early decrease of vision. And the one affecting dystrophies, the one that affects the endothelial, is cornea guttata that starts from the endothelial, but it can, starting from endothelial, can this tend to be central, become more prominent periphery, may have embedded pigment, so-called hazel Henle bodies, and contain collagenous matter in which numerous cracks and fissures are filled with extrusion of the corneal endothelial. It gives stromal edema, endothelial folds, cyst, pully, and subepithelial fibrosis. So the problem starts from endothelial but goes through the whole cornea, and with this makes a cyst in the epithelial that can break, and this is accompanied with enormous pain and pain, tearing, photophobia, and decreased vision little by little. And as we mentioned, vascular ingrowth into the cornea also starts. So when this clinical picture is in full at its maximum, actually we speak about endothelial dystrophy of Fuchs. It is actually decompensated cornea gutata. Other dystrophies can be polymorphous, posterior polymorphous dystrophy that affects the posterior stromum with edema and vascularization, subtle vesicular, geographic or bent-like lesions, frequently asymmetrical, and very often accompanied by increased intraocular pressure. Okay, corneal dystrophies are, so to say, according to their clinical picture, they all progress in different pace, but progress. Those that are in an anterior segment give this pain and recurrent erosions, but all lead to decreased vision more or less, and can end up in keratoplasty, transplantation of the cornea. So if cornea is the first 1/6 of the outer layer of the eye, sclera is the other 5/6. Unlike cornea that is shiny, smooth and transparent, sclera is porcelain white. It is collagenous structure as well, but the collagen fibers are very irregular in size and in arrangement, so it is white, unlike cornea. And we mentioned 5 reasons why cornea is smooth, shiny and transparent, unlike sclera, which is porcelain white. Here is the structure of the Episclera and sclera. You'll remember. What is important is these scleral apertures. Sclera is penetrated by various arteries, nerves, and even the connection with the cornea, which is a very typical limbus region, and behind the aperture for the optic nerve. Okay. So we have superficial vessels, episcleral vessels with radial configuration, and deep vascular plexus. Usually I ask, is cornea disease painful? Yes, the answer is yes. Cornea hurts. What about sclera? Yes, sclera hurts. So if you have inflammation, scleritis, we have pain, and both are part of red eye diseases. So scleritis and keratitis give red eye disease. Here are the apertures we spoke about. Episcleritis is the most common inflammation of the episclera. Superficial vessels are dilated, and like in a sectoral injection, not the whole eye but one area, you can have a nodule here, like elevation, or you can have it flat, but the problem is pain, okay, pain. And if you put adrenaline, this dilated vessel will stay because they're deeper than the conjunctival. It is a benign, self-limiting inflammatory disease. So if you prescribe non-steroid or corticosteroid for a few days, it will be healed. Besides pain, it may have tearing, photophobia, but can be easily healed. The problem here is to define the reason for this episcleritis, because it is usually a result from fungal infection, either teeth, nor sinuses, or even tuberculosis can give episcleritis, or some herpes infections. So here it's not a therapeutical problem, but it is diagnostical challenge, episcleritis. Scleritis are more specific. The real inflammation of sclera is usually part of collagen diseases, of autoimmune diseases. And this is a serious entity. We can't have scleritis just in every patient. We have scleritis in adult women with systemic disease, rheumatoid arthritis, or sarcoidosis. We have deep inflammation of deep vascular plexus, and we can have it in different clinical picture and severity. So we can have anterior scleritis. It can be non-necrotizing, nodular or diffuse, or necrotizing with or without inflammation. And we can have only posterior scleritis. So red eye is one of the hallmarks of scleritis. What about if you have posterior scleritis? All diseases with red eye and pain or with pain are actually red eye diseases. And if we have pain, posterior segment of the eye, like choroid and retina, they don't have sensory innervation, so we don't have pain in the diseases of posterior segment. So if you have chorioretinitis, you have some functional deficit, but not pain. If you have problems of the retina, oh, sorry. If you have problem of the retina, for example, retinal detachment, but you have some, again, functional deficit, like in the perimeter, in the vision, but no pain. If you have white eye with pain, because painful are red eye diseases, but if you have white eye and pain, there could be only two things. One is posterior scleritis, which is usually sclerouveitis. You see uveitis, but chorioretinitis, but with pain. That means it is sclerouveitis, posterior sclerouveitis. If we have pain, that means sclera is involved, posterior sclera. And what is the second disease that can give pain? White eye and pain. Can you guess? You already have neurology. What is the second disease? Are you there?
I'm not sure. Trigeminal neuralgia.
Sorry?
Trigeminal neuralgia.
I can't understand. But it's good you're there, not asleep. So the second one is neuritis. Okay, white eye and pain, especially moving the eye. So posterior scleritis and neuritis, retrobulbar neuritis, can give pain in a white eye. That's important when you have case reports to have as your test. Pay attention on every single word. For example, sudden onset, loss of vision, young person, pain, white eye, that's neuritis. If you have sudden loss of vision, adult patient with hypertonia or it's important after physical labor or waking up, it is vascular problem, either arterial or venous. So pay attention on every single word. So scleritis is equal to pain, and red eye when it's anterior, but when it's posterior, we can't see it, okay, if it's only posterior, but we can suggest it by having uveitis and pain. Only uveitis is okay without pain, but if sclera is involved, you have pain. So let's see anterior necrotizing scleritis. You see, that's the one with inflammation, severe pain. You see how uvea is visible, so sclera is so much thinned that uvea is seen, and it's progressive around the limbus. It's also accompanied with anterior uveitis and can give lots of complications, cataract, keratitis, secondary glaucoma. Actually, it's a systemic disease. Treatment is systemic prednisolone, but it's 25% lethal. You can have such anterior necrotizing scleritis without sign of inflammation. It is called Scleromalacia Perforans, so without signs of inflammation, usually women with long-lasting rheumatoid arthritis. So you see sclera is melting and uvea is visible. No effective therapy. And this is actually posterior scleritis. It's with not specific etiology, no association with systemic disease, no red eye, but there is pain. And you see some symptoms of chorioretinitis, some exudation of in the fundus. You see some folds on the choroidal. And actually, we suppose posterior scleritis by the pain, but we should make some differential diagnosis in the for a choroidal tumor or okay, B scan compulsory, and treatment is systemic corticosteroids. So